very good afternoon. It's around 12:45 in New Delhi, and I'm sure must be 12:15 in Pakistan. At the outset, I'd like to express my gratitude to my dear colleagues for inviting me for this talk. In particular, I'd like to have big thanks to Professor Abdul Malik, who asked me to give the talk on this very, very interesting topic that I'll be highlighting later. And also grateful to the chair, vice chair, moderator, and dear colleagues. I also heard Dr. Mohammad Wase, and before that, very interesting talk on about the pre-surgical workup and other talks, and with interesting case vignettes were very impressive. Congratulations, Dr. Abdul Malik, once again for organizing this wonderful talk. I'm working in New Delhi, India, and I'm currently principal director in a big healthcare group called Max Healthcare Group. And I'm going to speak on, is juvenile myoclonic epilepsy truly benign? Truly benign. So that's the topic. This is my brief introduction. I'll just run through it. With Allah's grace, around 450 publications, more than 100,000 citations, and we have I've written guidelines on epilepsy, which are available on website. And third edition of Puzzling Cases in Stroke is in the pipeline. Wase has contributed. Arslan Ahmed from Islamabad has contributed. And I'd like to invite other colleagues to contribute to this interesting book, which itself says Puzzling Cases in Stroke. These are some of my credentials. I bring greetings from New Delhi. Plan of talk, introduction and historical aspects of GME, prevalence and incidence, clinical characteristics, diagnostics, Indian and international studies, management. Then the answer, is it truly benign? Scientific basis. Because on the one hand, we say it's a benign, but we ask the patient to take treatment lifelong. Is it truly benign? Carry home message, I have around 55 slides, and there will be some cartoons and images. So I'm going to show you a video. I'll stop sharing this and show other video, which I sent to I don't know, I hope it should be visible.
Good morning. My name is Dr. Manmohan Mehdi.
Is it visible or not?
I am currently the Vice President.
I'll share. Sorry, it's not coming.
And I am working in the field of neurology.
Now it should be audible and visible.
My name is Dr. Manmohan Mehdi. I am currently
in the capacity as Vice President of International Bureau for Epilepsy Southeast Asia. I have sent this message, which is being played today world over.
For the last more than 40 years, I have been looking after people with epilepsy and their caregivers, how I can do best possible for them. Being from a low-income country
like Pakistan, India,
like the stigma, this about epilepsy, poor education,
which Professor Abdul Malik also spoke.
Huge treatment gap. So we coordinate with the other countries to do what I call intra-regional synergy, so that people with epilepsy of one country know the problem of the other country.
Like with Pakistan, inter-regional synergy.
Try to do inter-regional synergy. People with epilepsy connect with people of low-income countries, the high-income countries, and learn more about how things go there. So it has been our endeavor to do regular education, advocacy, and do the best possible for people with epilepsy and their caregivers. Thank you so much. Soon we have International Epilepsy Day coming, which is on 10th February, second Monday of February,
today,
which happens every year. And let us work together to bring epilepsy out of shadow and carry on our journey of epilepsy. Wish you all the very best, and I wish the world to be free of epilepsy or well-controlled epilepsy. Thank you. Good morning. My name is...
So the message here was, okay, I'll stop the video. I am
currently the Vice President of...
Okay, so the message here was like you are doing today International Epilepsy Day. It's celebrated world over. One correction I like to make, it's not World Epilepsy Day. It's International Epilepsy Day called IED every second Monday of February every year. So now I'll go back to my slides. Yeah. So next slide is, I think I'll not waste time on this. My previous speakers have talked about focal onset, generalized onset, unknown onset, what was earlier said like partial onset. That didn't make sense. So focal onset with secondary generalization, combined generalized and focal unknown epilepsy syndrome like juvenile myoclonic epilepsy. The previous speaker nicely talked about especially about the case from even Afghanistan, like structural, genetic, infectious, metabolic hyponatremia, immune, and unknown. So I'll go to my topic. So idiopathic epileptic syndromes, juvenile myoclonic epilepsy, childhood myoclonic abscences, juvenile myoclonic abscences, generalized tonic-clonic seizure on awakening. This is on Commission on Classification of Terminology of Epilepsies and Epileptic Syndrome. These are evolving. As you saw earlier, 2017 classification, then later classification. Now, I see a lot of younger colleagues in the audience, very attentively listening. Please make notes. Please make notes. This will be very helpful. All the speakers have worked hard to prepare this and pass on the knowledge from book to rather from the bench side to bedside. So one important aspect, Professor Abdul Malik said, not necessary to do EEG and MRI in every case. I'm highlighting history is most important. History is gold standard. History details to be inquired from all possible sources. Personal observation like video capture of the event. Please remember, tell your patient, most of them will come on mobile phone, but video capture of the event is very helpful. Now, another important announcement, there is no substitute for a good history. Again, highlighting personal observation of the seizures can be very rewarding. Carefully selected investigation can be helpful. In your country and my country, we cannot be American-like, American investigative, that get these tests done, come back to me, then I'll start the treatment. So this is one of my patient family who had myoclonic, generalized tonic-clonic, or what Delgado Escuta says, clonic tonic-clonic seizures with or without abscences. Here, this is the index case, which is male, and two sisters had abscences, fever, febrile seizures, and one had later on generalized tonic-clonic seizures. So this makes a complete, but usually happens in adolescent. Now, it's a clinical spectrum. This is different from generalized tonic-clonic seizures of idiopathic type. It has EEG changes which are different from generalized tonic-clonic seizures. Here AED, now we don't call it AED, we call it ASM, anti-seizure medicine choice is sodium valproate. No, used to be sodium valproate. Now no more, I intentionally written, now no more sodium valproate. Long-term prognosis is different. Usual clinical features of JME are sudden shock-like jerks involve mainly shoulder and arms. Person may not fall. Myoclonic jerks are usually bilateral symmetrical, sometimes asymmetric like this. Suddenly jerking happen. Sometimes fall may occur if they are in the legs or they are very severe jerking. 8 to 17% may remain pure impulsive petit-mal. Average interval between myoclonic jerk and first seizure is 3.3 years. So myoclonic jerks observed prospectively. This may be juvenile myoclonic epilepsy. This I'll show in a patient who had on premature awakening jerks. I'll advance this. Look, now observe carefully. It will come towards the end of the video. This is one of our patients. I recorded this in 2010. Now the jerk is coming. Look at this. This was in the arm as well as the shoulder. So it can happen both. The adolescent boy was sitting but didn't fall. Now this is the mother who is holding when the jerks happen. Okay, this may not be. So I'll go to next. Now listen from the person account. Young school boy.
अभी कितनी उम्र है?
The things fall from the hand.
Okay.
जब मैं चलता हूँ तो कभी कभी आंखें अंधेरा आता है तो मैं बैठ जाता हूँ तो फिर मैं ठीक करता हूँ कि ये
So he has abscences, jerks and abscences, two things.
और जब दिमाग को कुछ याद करो भूल जाता हूँ और नींद से आती है मुझे.
और कोई प्रॉब्लम? कभी बड़े दौरे तो नहीं हुए?
Please confirm this is audible.
फैमिली में किसी को ऐसे?
फैमिली में किसी को.
अच्छा, एक करके दिखा लो, झटका कैसा लगता है. ओके, अभी हाथ पे फोकस नहीं करिए.
Okay, I'll stop the video. It was primarily shoulder region jerks. Onset usually in adolescence, usually 12 to 18 years. I'm entering because Shazia Hassan, I'm admitting in the room. Jans D to 1969. Say almost, you can check 56 years back. What a observation. Great man. Myoclonic jerks on awakening or sleep deprivation, like the previous patient I have shown. Generalized tonic-clonic seizure. I'll request friends to, Saira, thank you so much for muting yourself. Generalized tonic-clonic seizure in 80 to 97% described by Pedersen in 1998. Abscences variable incidence 12 to 54%. Lankman 1994. Febrile seizure in 3 to 5%. So these are the distribution of type of seizures. Now, lucid account of a patient of JME. Thank you, Dr. Ahmad, in the room. Lucid account of a patient of JME under the care of Dr. Dieter Jans. Dieter Jans is from Germany. Now, what that girl described, I was a healthy child until my adolescence. At the age of 15 years, everything used to fall from the hand, like this boy said. Early morning, highlighted, bold, capital. I broke innumerable toothbrushes, glasses, and cups. You will say, how come toothbrushes? There used to be toothbrushes which had the end of a glass. My father hit me over the hands at the time because he thought it was my fault or it was hysterical jerks or I don't want to go to school. Now, but I could do nothing about it. My arms and hands jerked and I dropped everything. We consulted several doctors, but none of them was able to help me because this was till that time not well described. At the age of 16, I had my first seizure. That means generalized tonic-clonic, in which my tongue was bitten and I had terrible headache. Most of my seizures occurred in the morning or if I had to get up suddenly in the night. Now it's the responsibility of all the people who are in the audience through Zoom or in physical in the auditorium. Whenever patient comes with generalized tonic-clonic seizure, don't forget to ask about the history of abscences and myoclonic jerks. If you do that, once again, welcome Dr. Ahmed. So it is very important to ask this so that we can tailor the treatment, and treatment is different from standard generalized tonic-clonic seizures. Now, another very senior faculty member, Harpin, approved the description. Juvenile myoclonic epilepsy was first reported in France by Harpin. He described a bright boy aged 13 years who developed upper body jerks that progressed to full seizures 3 months later. He referred to these as myoclonic jerks as commotions epilepticus. Commotion, suddenly jerks happening. Something happened, like we see infantile spasm in children. Now, JME historical aspects are given here. I'll not read everything, but it was Dieter Jans who said epilepsy with impulsive petit mal. We are aware of these names. Dr. Mia Abdur Rahman, welcome. Lennox, Lund, Lundborg, Harpin, and main stands out is Dieter Jans, who described epilepsy with petit mal, impulsive petit mal. Now, this is a well-recognized, well-defined age-related syndrome classified as an idiopathic generalized epilepsy. What is the prevalence of JME? 4 to 11% of all seizures. Very important chunk, don't forget to ask. History of myoclonic jerks in generalized tonic-clonic seizures or in absences. Incidence of JME 0.4 to 0.9%. Now, seizure precipitating factors. When we are sitting in the outpatient or in our clinic, it is our responsibility to ask, does it occur on awakening? Does it happen because of sleep deprivation and fatigue, alcohol intake, mental stress, strong emotions, anxiety? When I talk of alcohol, I'm talking of global scenario. I know alcohol is not permitted in certain countries. Menstruation, flashing lights and video display, hyperventilation for EEG, bedside hyperventilation it may evoke absences and photosensitivity. Diagnosis, as I said, detailed history is of paramount importance. In a young person present, specifically pointed questioning, you must ask. Again, I'm saying myoclonic jerks is mandatory. EEG, video EEG monitoring is usually diagnostic. Now, large size Indian studies, these are some of my colleagues who have reported, and last is from our group, 2002, clinical expressions and EEG characteristic 103 families, Vijay et al. 183 probants. This was our article in 2002, which appeared in reputed journal Seizure, and we described the clinical spectrum. At that time, I was in GB Pant Hospital, Postgraduate Institute of Medical Research. Now, parameter 103 male to female ratio 1 to 1.9 to 1. Mean age of patient 21.91 years plus minus 7.12. Myoclonic jerks mean age of onset 14.46, so gap of 7 years. There I said 3.3, but in our cases it was 7.7. Generalized tonic-clonic seizure 15.95. First seizure 14.01. Delay in diagnosis is very common. Underdiagnosis and misdiagnosis is very common, 5.26 years, which is very high. And duration of illness 5.52 years. Now, seizure type, myoclonic jerks 103 out of 103, 100%. Generalized tonic-clonic seizure 75.72%. Absences 11.65%. Past history of febrile seizure around 10%. So the rest you can see the combination which was there, myoclonic jerks alone versus in combination. Now, seizure type in JME proband, this is the chart we published, myoclonic jerk, generalized tonic-clonic absences, febrile, and myoclonic jerk alone. But the EEG was fairly characteristic. In these cases, it's an electroclinical syndrome, thus it's mandatory to get an EEG done. To confirm the diagnosis, you will find polyspike and wave discharges. Now, distribution of myoclonic jerks and provocative measures. Premature awakening, 73.78%. Sleep deprivation, around 58%. Distribution of myoclonic jerks, arms and shoulder, 95. But look at quite high percentage, 25% in the lower limbs. Now, EEG spectrum, you can see ictal EEG, normal EEG, abnormal EEG in 79%. But if you do sleep deprived, then it's likely to be more abnormal. and 3 Hz spike wave discharge is coincidental, 11.7%. This is the analog. You must be surprised. I wanted to show original. When I was in postgraduate institute GB Pant, you can see here Foley spike and wave discharges happening in the first 3 seconds of the graph, which are fairly characteristics of JME. The incidence of febrile seizure was higher in our study. So we discussed that. There was a delay of 5.26 years because most of the patients go to physician. Sir, dora ho gaya, behosh ho gaya, generalized tonic-clonic, phenytoin, phenobarbital. No. One has to ask about myoclonic jerks and abscesses, and those are not advocated. Now, there is a surprise. In our 103 subjects, 10 subjects were already on phenytoin, clobazam, and carbamazepine. But seizures were very controlled. We didn't change. We did report this. Even it is mentioned if myoclonic jerks are controlled, but generalized tonic-clonic seizures are not controlled. It was in green neurology. You can add phenytoin or carbamazepine. So if patient is well controlled and no side effect, no toxicity, don't change. Genetic factor. The percent of genetic factor has been shown to be higher in this epileptic syndrome than in any other. Family history of epilepsy is positive in around 25% of subjects. This is our look at this one family chart. 5 members. Here JME, round 1, first one. Then JME, this has, and her sister children, 2 children, twin, had febrile seizures or febrile convulsion. So that's very important. So what did we do? Dr. Bhaskar Rao, one of my PG, did the thesis on this with IIT Kanpur of genetic study. Dr. Ganeshan had gone to Delgado Escuta, California, LA visit, and he was working there. When he came to the Kanpur, IIT Kanpur, then we thought we'll do a study of JME subjects and their family members in a university hospital in North India. So this study was conducted at GVPAN. All patients attending the neurology OPD and admitted who had JME were included. We had 50 subjects. Now this study suggested that polymorphism screened for BRD2 and LG14 which serve as a risk factor of JME in Indian population. Our study also suggested that genes associated with development and differentiation of nervous system are ideal candidate. The present study may provide the basis for further survey for BRD2 and LG14 polymorphism in JME and underscores the need for large-scale prospective studies. Now, neuroimaging. Routine neuroimaging is normal. We all know. I know, you know. Our neurologist community knows about it, but the guidance of the International League don't recommend routine neuroimaging studies in patients with JME. But that's what I'm going to now present, that it may show abnormal changes. There have been changes reported in the frontal lobe. There has been cognitive decline. And one I will show interesting case witness in the end, which had certain changes. Now, Indian perspective, not an uncommon epilepsy type in India. Various studies report prevalence as being around 7.7, which I said 7 to 11 in our country. Despite this, there is a considerable delay in the diagnosis of JME, which we said 5.26, our group said, Vijay et al. And Pangadia et al. Why delay? Why does it happen? The delay in diagnosis JME in India could be attributed variously to the relative unfamiliarity of many practitioners with JME and the failure to elicit a history of myoclonic jerks, which are very commonly neglected by most patients and their families. Indian perspective. JME commonly occurs in the relatives of probands. Mendiratta and Agarwal documented a positive family history of 25.2% in probands among first and second degree relatives. And similarly, Vijay reported little higher incidence than us. Now, myoclonic jerks were encountered in all. Murthy et al. Described the occurrence of predominantly unilateral myoclonic jerks in 16% of the cases. So it's the observation. Now onwards, you also observe and can have a database. I will be happy to collaborate with colleagues in Pakistan and make a larger database. Now, the incidence general tonic-clonic was around 75 to 80%. Mendiratta and Agarwal drew attention to the unusually high incidence of febrile seizures in their cohort. Indian perspective about EEG I have already described, but look at this in the second sentence. Focal, clinical, and electrographic features in patient JME have been reported, which came for review to me. So it is not usually benign. Now, most study reported a superiority of valproate in the treatment of JME, now no more. 63% patients showed good control with valproate. After a seizure-free interval of 2 years, they were successfully shifted to even smaller doses. On the other hand, Chakravarti et al. Reported relative resistance to valproate in 16% in Bengali population. This study highlights a possible difference in the genetic composition of different ethnic groups in India with respect to JME. Now, these are various studies which have been reported. This is what I was saying, Delgado Escuta in 1984. And you can see age of onset, delay in diagnosis. They also had, in US also had delay in diagnosis, prevalence of absences, initial. So this is a slide if any friend requires. I've already sent to Professor Abdul Malik, but if you write to me, I will be happy to send this. My email is mmehndi@hotmail.com @gmail.com. Now, genetics and inheritance, mode of inheritance yet not clear. Polygenic, digenic, monogenic autosomal dominant, monogenic autosomal recessive models have been reported by Ding et al. Now, these are the various chromosomes on which it has been localized. You can see 6p, HLA class 2, GABA RA5, GABA RA3, 15q14, etc. And these are other, this is still evolving. It's a polymorphism. Again, another slide, but I'll not go in detail. Another slide. Now, treatment options, I will take another 3-4 minutes and finish the talk. Valproic acid, yes. Dose, duration, withdrawal. Is it truly benign? Can we stop in what Professor Malik said, 2-3 years? Those are in routine cases of seizure which are not structural. And EEG become normalized. Then also 20% recurrence charges. Phenobarbital and Primidone, what is the status of phenytoin and carbamazepine? As I said, our 10 subjects were well controlled, so we didn't change. Neurades like lamotrigine, topiramate, levetiracetam, zonisamide, and also even brivaracetam. Now we have a preference of starting levetiracetam. Lamotrigine is a good drug, but can paradoxically increase myoclonic jerks. Now this video won't run, but you can see I took the video with consent. He's on valproate. Look at this. He has lost hair. He has gained so much of weight. And his seizures are not controlled. So this is the time to change from valproate. I changed to levetiracetam, took the video with kind permission and shifted to the what we call international proprietary name LEV, levetiracetam. Now, valproate used to be the drug of choice, effective as monotherapy. Adolescent don't give. Reproductive age group don't give. Don't give to women. We can try in men who are not in adolescent group, but telling them about the weight gain as well as the loss of hair and other things. Controls all types of, as it was said, as broad spectrum. Similarly now, levetiracetam is the broad spectrum. Don't undertreat. Average dose is 20 to 30 milligram per kilogram body weight for valproate as well as levetiracetam. When ASM are used in combination, doses need to be increased. Lamotrigine is the next most preferred, I said. Ideal for patients who cannot tolerate the adverse effect of valproate, especially in men. As I said, weight gain, tremor, hair loss. The boy had all three. European expert opinion study showed lamotrigine was first line choice for JME in adolescent, but now is shifted to levetiracetam. Now, levetiracetam received FDA approval for JME in 2006. Levetiracetam adjunctive therapy reduces all seizure type, so it's a good drug. Absence is not controlled, ethosuximide and clobazam, clonazepam, if generalized tonic-clonic not well controlled. Topiramate and zonisamide, which are sodium channel inhibitor, can also be helpful. Phenytoin carbamazepine may markedly increase the frequency of myoclonic jerks. But friends, read in the parenthesis. Is written, but not in all. That was in our study, 10 subjects we reported. Vigabatrin, gabapentin may increase absence seizure and myoclonus and hardly are ever used these days. Carbamazepine, tiagapen, vigabatrin may precipitate absence status epilepticus. So avoid. And now newer drugs are coming like Parampanel is available in our country. Cenobamate is being made available in our country. Let us see how the future comes. Now treatment options in JME, these are written in various studies were like VPA, LTG, TPM. You must know these. If you are going to be neurologist, these are international proprietary names. Phenytoin and carbamazepine better for GTCS if seizure myoclonic drugs are not controlled or generalized tonic-clonic are not controlled, you can add this. Now prognosis, seizures are well controlled with medication. 86% get controlled with valproate alone if can be given or with levetiracetam. Now important, anti-seizure medicine usually to be continued lifelong. Not only to be given for 2 years or 3 years. So how is it benign?
Sir Manmohan, we are due to time constraint running out of time.
Just one slide, 1 or 2 slides. I'll just jump. Okay, neuroimaging can show abnormality. Look at this. Basal ganglia calcification and had classical JME. That's why I'm saying it may not be benign always. Is JME truly benign? I give the evidence here. Is it truly benign? Again, like in most cases, treatment is to be taken lifelong. These findings are increasingly casting doubts on the popular notion that JME is a benign epilepsy. Now, carry home message. JME is an important form of generalized epilepsy. It is still under-recognized, under-diagnosed or misdiagnosed. Treatment needs to be taken lifelong. Levetiracetam is the newer drug, valproate to be avoided to avoid neural tube defect. More and more neuropsychiatric and neuroimaging abnormalities are being recognized, thus no more a benign condition. Thank you very much for the kind attention, and I'm sorry for exceeding the time.